All right. Hello again, everyone. We are in the last portion of this dysrhythmia part of your perfusion content for Unit 1. So let's go ahead and get started with this. At this point, we've looked at what's normal on an EKG strip as well as what is abnormal. So now we're going to look at the rhythms that lead to having no pulse. So we'll call those the lethal rhythms, meaning that they are lethal and they will kill you. So we are going to look at the lethal rhythms at this time. They are going to be inconsistent. These electrical patterns are going to be inconsistent with maintaining perfusion. So our first one we're going to look at is ventricular tachycardia. So technically, ventricular tachycardia is going to be defined as having 3 PVCs in a row. So if you have 3 PVCs in a row, that's considered a 3-beat run of VTach. But what we're going to look at is sustained VTach. So not just the 3 in a row. Typically, that's going to be mostly asymptomatic. So it's going to depend on how many in a row. You may have a 30-second run of VTach, a 10-second run of VTach, a 5-second run of VTach. So it's going to depend on how is it impacting perfusion is going to impact how we're going to treat it. So just like with everything else. But what we're going to talk about in this part is sustained VTach. So if you remember from our previous PowerPoint when we talked about tachycardias, we talked about them being narrow complex. We talked about narrow complex tachycardias. Ventricular tachycardia is a wide complex tachycardia, meaning that, let me get my little pencil. So meaning that these complexes are wide, where in a narrow complex tachycardia, you've got, and I think I explained this before, you've got that QRS still, and it's narrow. So that is going to be what we're talking about here, is this wide complex tachycardias. So the ventricular tachycardia can be caused by cardiac ischemia or infarction, so not enough blood getting to the heart tissue. Increased workload of the heart. If you have heart failure, that myocardium is all stretched out, that can lead to ventricular tachycardia. Also sustained narrow complex tachycardia. So if you've got a narrow complex tachycardia that's going on and on and on and on, and that heart's just pumping and pumping and pumping and pumping and working so hard, eventually that can switch you over into these wide complex ventricular tachycardia as well. Digoxin toxicity, hypoxia, acidosis, all these are going to be causes for ventricular tachycardia. Electrolyte imbalances, low potassium can throw us into this VTach. Also, what we see a lot is people with that low ejection fraction after a MI. So then we're looking at that low ejection fraction is showing that that heart's not pumping everything out like it needs to, right? It's not getting enough blood out of the heart at a time, and it doesn't have enough muscle to work because already some of that muscle's been damaged from that MI. So how you treat it is going to depend on the characteristics of the ventricular tachycardia. So let's check that out. So as I talked about, we talked about the narrow and wide complex of tachycardia. So ventricular tachycardia, you can have a pulse with it. We don't see that as much, but you definitely can. I have seen it. I've seen somebody maintain VTach with a pulse for a very long time, actually. So you can have these wide complex tachycardias with a pulse. So that's going to be the very first thing we're going to check, right? If you pop up and you see these rhythms on your monitor, you see this, or you see this one up here, you see this happen on the patient's monitor, the first thing you're going to do is go check a pulse. You're going to go assess your patient. Remember that nursing process. Very first thing, assess. We're always going to check a pulse. If you have a pulse, then you are going to follow that same algorithm that we used with tachycardia. Sorry, I didn't mean to pause my share. So we will, if you have a narrow complex, if you have a wide complex, but you've got a pulse, you're going to follow that tachycardia algorithm. So we'll talk a little bit more about that in a few minutes whenever we go over these lethal rhythms and treating them. Because if you don't have a pulse, regardless of what's on the monitor, we're going to follow a different algorithm. So we'll kind of go over all those at the same time. So I'm going to hit on that tachycardia with a pulse algorithm at that time in just a few minutes. Oh, I think I went back too far. Yes, I did. Sorry about that. So we're talking about the characteristics. So first thing, with or without a pulse, is going to change how we're going to treat it, right? The next thing we're going to look at is these, and we talked a little bit about this with PVCs, is this polymorphic or monomorphic. So mono is one, poly is many, morphic is talking about what it looks like, the shape of it. So see this down here, these down here, all of these complexes, this is from a 12 lead, so these are 4 different leads right here. So that's why they look kind of different. So, but all the complexes in this lead, all the complexes in this lead, they all look the same. These are all one lead down here. They're all the same. They're all the same shape. So they are monomorphic. They are the same shape. They are monomorphic. If we look at this rhythm strip, you see this looks kind of crazy, doesn't it? Excuse me. This is what we call polymorphic. So this is still a ventricular tachycardia, but the shapes are different. So this is what we call polymorphic ventricular tachycardia, is when the shapes are different. They've got different shapes and complexes. So this particular rhythm is got its own specific name. It is called torsades, and it is characterized by this pattern that looks kind of like sound waves, right? It is this pattern here. So you see how it's got this large, small, this wavy pattern. So that is torsades. So torsades specifically is typically caused by medications. It's usually preceded by a prolonged QT interval. Remember, we talked at the beginning about how with some medications, we may be monitoring the QT interval. And so if you start to see elongation, it can lead to this torsades. Another thing that can lead to torsades is low potassium, calcium, or magnesium. And honestly, magnesium is what you see the most often. When you see this on the monitor, you automatically are, let's check the magnesium level, because that a lot of times is what is the cause of this torsades, is that magnesium level. So it is likely to cause the patient to deteriorate and become pulseless, even if they didn't start pulseless. So we need to do immediate intervention and treatment of the cause. If we don't treat the cause, we are not going to be able to fix the problem. So we need to assess what is the problem. If it's low magnesium, we need to give them some IV magnesium now. And if it is, and if they don't have a pulse, then we'll talk about that when we get to treating pulseless rhythms. But if they have a pulse, the priority with torsades or polymorphic ventricular tachycardia is going to be to treat the underlying cause and get that taken care of. Some of the medications, antibiotics, some types of antibiotics like Cipro and Zithromax can cause torsades. Lithium, Haldol, methadone is another group. I will tell you, I did one time have a elderly patient. She was in her mid 90s. I think she was 96, and was a very, very healthy 96-year-old. Still lived independently, drove her own car. She was gardening and passed out. Her neighbor saw her, called 911, and she was going in and out of torsades without a pulse. So every time when she was going into the torsades, she was coding and going through CPR. She had broken ribs. It was rough on her. And it ended up, they were trying to figure out the cause because she'd never had any cardiac issues. She had no history of cardiac disease. Her EF was good. Everything looked normal, but they actually had her scheduled to put in an internal defibrillator because they're like, we don't know why, but we're going to have to fix this. Are you just going to, and you're just going to die because it's going to keep happening. Well, somebody started reviewing her like what was going on before she came in, and she had just finished right before she came in. She just finished a round of Cipro for a UTI. So she was going into torsades from that Cipro, and so after that cleared her body, then she was good to go. So which I just thought was the craziest thing. I'd never seen that. So keep that in mind. All right, let's look at our next lethal rhythm. Is going to be V-fib. Now, V-fib does not have a pulse. It's not like the V-tach where you may or may not have a pulse. That said, you still need to check your patient before you start banging on their chest. They might have a lead off. Sometimes, you remember, treat the patient, not the equipment. So if you go in, if you see this on the monitor, you run in, Annie, are you okay? She doesn't have a pulse, call the code. So go ahead and I don't even know if they still do Annie, are you okay in BLS and ACLS classes anymore. So I might have just shown my age saying Annie, are you okay? But if, so still make sure they don't have a pulse, but V-fib is not one that can have a pulse. If that's the true rhythm, then you immediately start CPR. And we're going to go through that algorithm in a minute. So I want to point something out to you as far as identifying V-fib or V-tach. So remember, V-tach can have a pulse, V-fib never has a pulse. Just those two things. Then I'm going to show you, so let's flip your minds back to the last presentation when we talked about AFib and A-flutter. Do you remember that AFib was atrial fibrillation, was disorganized chaos in the atrium? Remember, it was just like in the atrium and nothing organized. So this is the same thing, but it's in the ventricles. Same thing as AFib, except for in the AFib, it's just happened in the atrium. You still got the ventricular beats, right? Well, with VFib, this is happening in the ventricles. So you got nothing. You got no perfusion. Just like how we lost that atrial kick and the pump from the atrium into the ventricles with AFib, now that's happening in the ventricles, so that's happening everywhere. We have no ventricular contractions to perfuse blood throughout the body. So I'm going to go back to that V-tach. So, and V-tach is kind of the same. It's going to be electrically, it's going to be similar to the A-flutter, where it's more of an organized pattern. So, but it's happening, again, it's happening in the ventricles, not in the atrium. So I hope that, I don't know, hopefully that didn't confuse you more. Hopefully that helped you. But you've got two different rhythms with fibrillation, atrial and ventricular. So then you remember, fibrillation is just jittery nothing, disorganized nothingness, disorganized chaos, where the V-tach or the A-flutter is a more organized, not perfusive though, where with the V-tach, you can still have a pulse, but it's not going to be a strong pulse. It's going to be not as effective as a normal beat. Okay, so let's talk about the last of these lethal rhythms. Well, it's not, I take that back. The next to last lethal rhythm we're going to look at. Asystole, so nothing, flatline, no electrical activity. If there is no electrical activity, there is no being. There is no electricity. There is nothing. At least with VFib, you've got electrical activity in there. It's just super disorganized, and we want to get it back to being organized. With asystole, there's nothing. There is no electrical activity. That said, always same as the others, assess your patient. Always check it in multiple leads, because if your leads come off, sometimes it'll show asystole on the monitor. Nothing freaks out a patient more than whenever a whole team of people come running in to see if they've got a pulse, and they're just standing there and their monitor fell off. But that's what we're going to do. We're going to run in and make sure they're okay. It's just like with VFib. What am I doing? I'm brushing my teeth. Guess what this is doing to this lead right here? And so I've seen that multiple times. I have run in on people brushing their teeth multiple times, where they're brushing their teeth and their monitor looks just like VTAC. You run in there, are you okay? Yeah, are you okay? So always assess your patient. Treat the patient, not the monitor. So the last thing we're going to talk about is PEA, or pulseless electrical activity. This is a condition where you have electrical activity, but it is not causing contraction within those myocardial cells. So what you have is electricity with no squeezing, no movement, nothing happening. What is actually happening to the heart muscle is it's like asystole would be. But there's an electric, what you'll see on the monitor looks just like, it could look like anything. It could look just like this normal rhythm, but there is no pulse. So any rhythm, it doesn't matter what it is you see on the monitor, if there is no pulse with it, then that is considered pulseless electrical activity, and it is bad. So typically, I know Miss Doig has said that she has had patients just like go in, like they've been fine, and then go in the room, and then all of a sudden that they don't have a pulse, and this is what's going on. I've not actually had that happen to me before. When I've seen PEA, it's been on the back side of a code. After we've been coding somebody for a long time, we've gone through all the rhythms, and they've already been asystole, and then all of a sudden we start seeing this PEA, and typically it's bad. Typically PEA and asystole a lot of times are they're less likely to recover from than they are a VTAC or a VFib. All right, so I've got this little video we're going to watch on the rhythm progression, and then we're going to talk about what we're going to do about when we see one of these abnormal rhythms. What are we going to do about it? So, all right, so I'm going to start off the top here. Before I start this video, let me get my little pencil out. Some of you guys maybe have already recognized what's the problem with this rhythm. So we've got let's go back to thinking about what makes a rhythm normal. So we've got P wave for every QRS, right? P waves, QRS, we got those. We don't have any lines, so we can't measure out what our PR and QRS intervals are. But we're going to assume this is normal. But I hope you guys can recognize this doesn't look normal, right? This doesn't look like those normal strips we look at. So let's dig it through it and see what's this problem. What's going on in this EKG that we're looking at here? So we've got the P wave, right? We've got our QRS. So here's our QRS complex. Here's our isoelectric line where everything returns to. And here is where our T wave would be at, right? Here's our T area, our ST area. So what we've got here is this is elevated, right? This is not returning. This QRS complex is not returning to the isoelectric line. It is there. This is the T wave right here. And what we've got is that this QRS complex is not returning to that isoelectric line. So this is ST elevation. ST elevation. Can you guess what the next two letters are? STEMI. We got a STEMI going on. So let me clear all my drawings, and then we will start this. We were going to start this video of rhythm progression. Sorry about the dramatic music. Okay, so we've got a PVCs popping in. They're starting to gather together with their friends. That's not good. Uh-oh. Okay. VTAC. So this could be with or without a pulse, but it's a regular pattern. Okay, so now we've switched over, and it looks kind of like a coarse fib or a corsage, but it is getting worse. Okay, so now we're definitely in V-fib. We've got a small disorganized rhythm going on. And now we have gone into flatline, and there is no electrical activity at all. Okay, so let's talk about what are we going to do about it? What are we going to do? So, as I've said, the first thing we're going to do is assess. We need to see, what does this mean? And again, we're going to go through our same talking about this being stable versus unstable. Remember, VTAC can have a pulse. So if you have a pulse, then you've got perfusion. You've got some perfusion. So then the question of stable versus unstable is, how well are they perfusing? So if you've got a pulse, are they stable or unstable? So remember, stable means it's an abnormal EKG, but that their vital signs are stable and they have no signs and symptoms of altered perfusion. So no complaints of shortness of breath, chest pain, no confusion, no pallor, sweating, nothing like that. They are fine. They feel fine. They feel great. Everything's great, except that their heart rate's 180 with a Y complex tachycardia. So is that normal, or is that usual? Is that something you will usually see? No, but I have seen it. I have seen people with a stable Y complex tachycardia before. So we're going to look at we'll go back through that tachycardia algorithm in just a second. I'm looking at if they're stable. But most times what you'll find is that they are unstable or pulseless. So unstable patients will have the same rhythm, but their vital signs are not stable. We have signs of poor perfusion. So low blood pressure, they're diaphoretic, they are short of breath, chest pain, level of consciousness is a big one. So are they confused? If the rhythm is not treated immediately, if somebody has an unstable lethal rhythm, or otherwise, if somebody has an unstable rhythm that is left untreated, that patient may die and should be treated aggressively to get perfusion back where it needs to go. So, and then lastly, if somebody is pulseless, so if there is no pulse, there is no perfusion, then it is going to be an emergency. This is a code blue. This is an urgent situation. We are going to, oops, sorry, I've got, I was messing with my mouse and got scrolling. We're going to need to begin CPR immediately. Okay, so let's look at our algorithms and see what we're going to do. So first, we're going to go back to this same algorithm that we looked at on the last PowerPoint with tachycardia with a pulse. So if you've identified ventricular tachycardia on the monitor or torsades and you have a pulse, this will be the algorithm you're going to use. So we're going to go through our algorithm here. My handy dandy pencil out and ready to go. I do think I want to change colors to a nice green. So the first thing, so we've seen that they are tachycardic and they have a pulse. If they have a pulse, If they do not have a pulse, this is not the algorithm we're going to follow. If they have a pulse, it will. So first thing, we're going to try to identify that underlying cause. We're going to get them hooked up to the monitor. Basically, we're going to assess, right? We're going to assess them for the cause. We're going to assess their blood pressure. We're going to assess first. So then we're going to continue our assessment and see, are they stable or unstable? So that's our questions here. Is this a stable or an unstable tachycardia? If it is, if they do not have any of these signs and symptoms and they are stable, we're going to look down here. We're going to drop down here. So we're going to assume our patient is in VTAC, but they are stable right now. They have none of these signs and symptoms. So now look, we've got this box. We talked about it briefly on the last one, but I said I would come back to it. So now I am. So what we have, a wide QRS with VTAC, that's what we have, is this wide complex tachycardia. So now we're going to go over here to yes, we do. All right. So what we have is to consider. So this is what we're going to think about. Adenosine, remember adenosine is the medication we need to educate on because it's going to make them feel like their heart just stopped, which it kind of did for just a second while it reboots. Only if it is regular and monomorphic. So adenosine only if it is that regular VTAC pattern where all the complexes look the same, not that torsades with the weird pattern. We may start an antiarrhythmic infusion. So I want you guys to think about too, let's remember back, VTAC could be categorized as 3 PVCs together. So we're going to treat this the same as, we could be treating it the same as we would with PVC. So an antiarrhythmic medication like amiodarone is a big one that we see used a lot. So stable VTAC, we maybe want to consider beginning an amiodarone infusion. Here's the dosage here. You guys can read. And then we're also going to get an expert in. We've got somebody who is feeling okay, but they are in VTAC, and we know as providers that their heart cannot keep up that hard work forever. So we know that we're going to need at some point somebody to come in and figure out, we need somebody to come in and figure out what's going on so we can fix it. So if you've done those things and it's continuing, so if refractory, so refractory meaning it's not responding to treatment. That's what refractory means when we talk about rhythms. Refractory means that it's not responding to treatment. So then we need to look at treating the underlying cause. If we've done cardioversions, which is up here, then we need to increase the energy level, add additional. If you've only cardioverted, then we want to add an antiarrhythmic drug to it, and then still basically what we need to do if we can't get it to fix, we need to figure out what's going on and fix the underlying problem. That's what this all boils down to. So let me clear my drawings. We're going to go the other direction. If we've assessed, we found that our patient is tachycardic, we have done our assessment, we're moving down here to see, are they stable or unstable? So this time we're going to say that yes, they do have hypotension and altered mental status. So this time we're going to need to go this way. So this is going to be the same. Remember, this is the same algorithm that we looked at with narrow complex. It just has this down here that changes, where if you have a wide complex, then you have to look at things a little bit differently than you would down here if it was narrow complex. But this part is the same. If you have a unstable tachycardia, you treat it the same, whether it's narrow complex or wide complex, with a pulse. Unstable tachycardia with a pulse always goes the same way. We need to do a cardioversion. We need to do sedation. If it's narrow complex, then we may do adenosine first. If it's wide complex, we're probably going to skip on down to the synchronized cardioversion. So remember, synchronized cardioversion, meaning that you're hitting it at the right part. They're going to be getting that electrical charge at the right time during that QRS complex so that it doesn't cause an arrhythmia. So Remember, the big thing to remember with the defibrillator, the difference in cardioversion and defibrillate, those two terms are not the same thing. Cardioversion means that they have a pulse and you are timing it up. Defibrillation, the patient does not have a pulse. You aren't timing it up with anything because there's nothing to time it to. So that is the big takeaway there. Cardioversion, you do it with a pulse, and defibrillation you do when there is no pulse. So let's move on to talk about what else we're going to do when there's no pulse. All right, so if they do not have a pulse and you have assessed and you have found that they do not have a pulse, the first thing you are going to do is compressions. That is what is first. You are going to get on that chest. Yell for help, call the code. Chest compressions first. Time is tissue. If there is no pulse, there is no perfusion to the brain or other vital organs. High quality chest compressions save lives. So you are immediately going to start chest compressions. That is what comes first. So we are going to remember good quality chest compressions. So let's talk about what does good quality chest compressions mean. So first of all, if you have good CPR going on, it's going to keep the vital organs perfused until you can get medications and a defibrillator. You should minimize interruptions to chest compressions. We used to take all these breaks when we did CPR. We'd be doing chest compressions, they'd be like, okay, I'm getting the pads on. And we'd all stand there while somebody's getting the pads on. Then we'd stand there while we're checking the rhythm. Then we're standing there while we're charging the machine. And all this time, our patients were not getting perfusion to their vital organs. And what evidence-based practice showed was that we were killing our patient's brain tissue basically by just standing there waiting for things to happen. So now we minimize our breaks in CPR. We are chest compression up until like we're ready to put the stickers on. It's less than 10 seconds you should be stopping. Stick them on, right back on the chest. And then you continue them. Okay, we've got a shockable rhythm. You know, you can stop for a second, analyze. Okay, it's shockable. Back to chest compressions. We're charging the machine, setting to, 200 joules, 360, whatever they're setting it to. We're going to keep pumping until that machine says it's ready to shock. Then they're going to say ready to shock, clear, shock, back on the chest. We used to, then we would shock, we'd stop, we'd analyze, we'd charge the machine, then we'd shock them. Then we'd stand there some more and wait to see what's it going to look like when it finishes. Right back on the chest. So we're going to minimize those breaks and save our patients' brains. So consistent high quality chest compressions are essential for successful cardiac arrest resuscitation. Each compression should be at a depth of at least, and I'm talking about adults right now, should be at a depth of at least 2 inches. And when you are pumping on somebody's chest, that is a lot harder than what you think it is. So hopefully when we do our activity, hopefully you'll get a chance to practice compressions. If you have never done compressions on a person before, it is harder than what you think. And it's not, I don't know, it's hard. It's harder than what you think. It's also, when you do it, if you're doing chest compressions on a little old person, you can feel their ribs break underneath you. And it's just not a great feeling. And so, but at the same time, broken ribs heal. Dead brain tissue doesn't. So you still go forward with those deep chest compressions. Depth of at least 2 inches, not more than 2.5. You also need to make sure when you do those chest compressions that you also come all the way back out, allow for full recoil, because it's the same as, let's say, a tachycardia that's squeezing, so you don't get the refill, you don't have time to refill. It's the same if you're doing chest compressions. You've got to, if you're manually squeezing that heart, right, you're manually pumping, if you don't allow for recoil, the heart can't fill back up. So 2 inches in, full recoil back. Compressions should be delivered at a rate of 100 to 120 times a minute, and should only pause for when you're switching out or actually physically delivering the shock or something like that. And as I said, 2 inches, at least 2 inches, full recoil. These are priorities with chest compressions. Placement, you put your hands just above, like 2 finger breadths above that xiphoid process, just right in that sternum there, right in the middle. We used to, I heard, I haven't actually had this confirmed, and maybe because I'm in denial about it and I don't want to confirm it, but I heard that they are changing, the American Heart Association is changing the song from Staying Alive to Baby Shark, which sounds awful. So we used to, basically, to make sure you're getting the right number of compressions, you could do the song Staying Alive, Staying Alive, Staying Alive, and that gets you that 100 to 120. The other thing that also does it is why can't I think of, like, the Evil People's song on Star Wars, dun 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 dun. Also, but Staying Alive is what I actually don't usually sing to myself during a code, but I do when I'm doing my training. So that's the speed there. All right, so we've talked about chest compressions. Let's talk about defibrillation. So remember, difference in defibrillation and cardioversion. Cardioversion with a pulse, defibrillation without a pulse. So they must have no pulse, no organized electrical activity that's leading to perfusion. So both of these rhythms here, but they have to have electrical activity, okay? So let me get my pencil. I'm gonna change away from purple. It seems inappropriate. Let's do red. Okay, so we've got VTAC with a pulse, or without a pulse, sorry. We've got VTAC, and we've got VFib. So we're going to, at this point, this is a pulseless VTAC, and VFib never has pulse. So what we have is disorganized electrical activity in the heart that's not leading to perfusion. That is what we have to do a defibrillation. Have to have electrical activity, but you also have to have no pulse. So you should have electrical activity with no perfusion. So what we have here is what we need. Shockable rhythms, VTAC, VFib. Those are your shockable rhythms. Asystole and PEA are not shockable. You cannot defibrillate asystole or PEA because you don't have like the myocardial cells don't have any electrical impulses within them. So asystole and PEA cannot be defibrillated. Only VTAC and VFib are shockable rhythms. So what is the priority for somebody in VFib or VTAC, pulseless VTAC? The priority is defibrillation. That's what's going to get that rhythm back into a normal pattern. So you'll hear you'll hear us talk about biphasic or monophasic defibrillators. So monophasic defibrillators are the older type, and electricity moves in one direction. So you need more electricity. If you have a biphasic defibrillator, so these are my defibrillator pads on both sides of my patient's heart, right? Or here and here. But so if you have biphasic, that electricity is going to go in both directions. So you can use less electricity than you do with the monophasic. So with monophasic, you're going to go ahead and start with 300 joules. With biphasic, you can start between 120 and 200, but typically you go ahead and start at 200. Okay, so let me clear my stuff. We are going to look at that. This is the adult cardiac arrest algorithm. So this is what we are going to see if this is what we are going to use if your patient does not have a pulse. Does not have a pulse. Any pulseless rhythm, it doesn't matter what it is, pulseless rhythm, this is our algorithm, okay? All right, so let's look at our pulseless algorithm. So we've determined at this point, let me get my pencil. I'm gonna use blue for code blue. Okay. So at this point, we've determined that our patient is pulseless. First thing, number one, top of the list, start high quality CPR. So that is the very first thing we're going to do. Start CPR and get them attached to a defibrillator. Next up, we're going to determine, is it a shockable rhythm? So remember, shockable rhythms, VTAC, VFib, not shockable rhythms. Asystole and VTAC and PEA. So it's listed on here. See how much I love algorithms? It says it right on here. So you need to be very familiar with these algorithms. You basically need to memorize this pathway here. So let's start with shockable. So you've got a shockable rhythm. We've got our patients in VFib over here. So what are we going to do? We've started CPR, we attach them, we determine they're in VFib. As soon as that happens, we're gonna shock. That's what we're gonna do. Shock, 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 shock. First things first. So let's look, I just wanna go back over to the side over here because this algorithm also goes into great detail about everything that we're doing, okay? Over here, we've got CPR quality. So this first box is going to tell us over here, what does that even mean? We're going to start CPR. Okay, well, what is that? Push hard and fast and allow complete chest recoil. Minimize interruptions. Avoid excessive ventilation. So we're going to talk about ventilation in a minute. I'm not going to go there right quite this very second. So change compressors every 2 minutes. This is important. I don't care if you think you are Captain America and you can continue your chest compressions for the next hour and you feel like you'll be okay. Every 2 minutes. You can go back in 2 minutes later after you've rested. 2 minutes tops. Every 2 minutes, you switch roles because even if you don't think that you're tired, I promise you, your chest compressions have decreased in effectiveness and your patient's brain is paying for it. Your pride isn't worth your patient's brain. Switch roles every 2 minutes. So if there is no advanced airway in place, meaning they don't have a ventilator tube in, they don't have an ET tube or any type of an advanced airway, we're gonna do chest compressions and ventilations at a rate of 30 to 2. 30 chest compressions, 2 breaths. 30 chest compressions, 2 breaths. And I'm going to talk about capnography in just a little bit, so we're not going to talk about that right now. So we'll get back to that. So then we also, just like we talked about a little bit ago with the defibrillators, we've got information about our shocks over here. So our shock energy for defibrillation, what does that mean? If we've got a biphasic, we're going to go with the 120 to 200. Okay, I don't know if y'all can see that, but this thing just popped up on my screen. Okay, 120 to 200. And if you don't know if it's biphasic or monophasic, you're going to go ahead and turn it up, crank it up, because you don't know. So if it's monophasic, we're going to do 360 always, basically. So if you are using a biphasic defibrillator, the second and subsequent doses should be equivalent or higher. So meaning if you started with 120, you shocked them at 120, then the next time you shock them, you're at 200. The next time you shock them, you're at 360. You're going up every time, or at least equal. But typically you're going to go up until you get to the maximum, and then you're going to stay there. All right, so let's get back over here. We started CPR. We identified that we're in VFib. We have shocked. We have delivered a shock. We are immediately going to go back onto the chest, immediately. Shock, sit, continue CPR. So we've continued our CPR. While we're doing CPR, we're going to check and see if we have IO or IV access. We're going to get that going. So 2-minute CPR and then shock again if we can. If it is a shockable, but every time before we shock, we're always going to assess, is it a shockable rhythm? So CPR, shock. CPR 2 minutes, shock if you can. After the next shock, we're going to start looking at medications. So we are going to give epinephrine. Let's look over here, back over here. It shows us about our drug stuff. So top spot goes to epinephrine, and 1 milligram of epi every 3 to 5 minutes. So we will continue to do that. Epi every 3 to 5 minutes. We will continue throughout the code. So we've got epi we will give during this next round of CPR. So let me erase my pen marks because they're starting to confuse me. Okay. So we're going this path, CPR, shockable rhythm, shock. CPR for 2 minutes, get your IV or IO access ready. If you've already got access, you're gonna go ahead at this 2 minutes here, you're gonna spend getting IV fluids running, getting some normal saline wide open so that you can push things through. So that's what you'll be working on here. So getting some IV access ready. When we get that IV access ready, it's probably been about 2 minutes. Then we're gonna assess our rhythm again. If it's still shockable, we're gonna shock them. Next thing, next 2 minutes, everything's in 2-minute chunks. So the next 2 minutes, we're gonna go ahead and administer our epinephrine and consider an advanced airway and capnography. So advanced airway, meaning an ET tube that would be placed by a physician. A lot of hospitals have a respiratory therapist that do them. Nurses can do it if they are trained to do it, but typically most hospitals, it's gonna be the physician or the respiratory therapist. And then we're kind of gonna go on through our algorithm here. They're still in VFib. We're going to shock them again every 2 minutes. CPR 2 minutes, shock them every 2 minutes. We're going to continue. It's just in that in between during CPR, we're going to do other things. So CPR all the time. Every 2 minutes, we're going to assess if we can shock them, and we are going to do it if we can. And then during the 2 minutes of CPR every time, we're going to do something else. So the first 2 minute break, we're going to spend getting IV access. The second 2 minute break, we're going to go ahead and administer epinephrine. And consider getting an advanced airway in place. Then this next one, we're going to consider starting some amiodarone and treating reversible causes, which are down here. See, got the list down here. I'm going to go over these on the next slide, so we're not going to talk about these right now. So remember, 2 minute cycles, CPR, shock every 2 minutes if you can. Epinephrine, it's the first thing you give every 3 to 5 minutes. So you can't give it every cycle, remember, because it's 2 minutes, so you won't be able to give it every cycle. So like this cycle here, we may be down here, we may be placing that advanced airway. We may be going ahead and starting an amiodarone drip trying to figure out what's going on. But then it would be this next cycle, because this will just continue. This is just going to continue. We're going to keep doing this over and over and over till either we stop or we get a rhythm back. So you know, this is going to continue. So then it would be the next one. We'll give another dose of epinephrine. So another milligram of epinephrine. So every 3 to 5 minutes until CPR is finished, or you, well, whatever led you to stop CPR. All right, so that is going to be what we're going to do when we're going through that shockable rhythm. So now let's look at what are we going to do if we have a not shockable rhythm. First things first, high quality CPR. Get this oxygen. Okay, so now we're back on this other side. I am going to go ahead and take a minute to talk about this. So we're going to get an ambu bag going. We're going to go ahead and get that seal, get the good seal around the nose and mouth, open up the airway, and administer breaths. So we've got some down here, avoid excessive ventilation. So we're gonna, when you hook up a ambu bag, you're gonna go ahead and crank that oxygen all the way up, okay? All the way up. Another thing, you're not gonna leave that mask on their face. You give them their 2 breaths, 30 to 2, give them their 2 breaths, look for chest rise. You wanna confirm you're getting chest rise, but you don't wanna squeeze that bag all the way to where it's an overventilation. You're gonna build up air in the stomach and can cause damage that way. So we're gonna get a good chest rise and then let go. Chest rise and then let go. We're not gonna leave the bag on their face, leave the mask. We can put it to the side. So 30 to 2, every 2 minutes. We're gonna get that oxygen in there. We want high concentrated oxygen for those 2 breaths. And we're gonna do compressions and get that oxygen down, out into the body where it needs to go, into the brain and vital organs. So we have now determined it is not shockable, not shockable. So what are we gonna do? We've got the other rhythms, asystole or PEA, that are non-shockable rhythms. You're gonna give that epinephrine ASAP. So as soon, they used to have you doing CPR for 2 minutes and then giving this epinephrine in the next 2 minute slot. So now if we identify asystole or PEA, we're gonna start CPR and we're gonna get that epi in ASAP. So that is the big change, is that you're not gonna, if you've got asystole or PEA, you don't do CPR for 2 minutes before you give epi. You immediately give the epi. But again, CPR first. And then while you're doing CPR, get that epinephrine in. Every 2 minutes. So the difference here, we can't shock this rhythm, right? So literally, let's go on down this algorithm. So we've got epinephrine, consider advanced airway and capnography. So getting that ET tube in. And then if it remains a non-shockable rhythm, CPR for 2 minutes and treat reversible causes. Literally what you've got in your toolbox, if you were asystole or in PEA, you've literally got epinephrine and CPR. That's what you got. So you're going to be getting your advanced airway in. You can give epinephrine every 3 to 5 minutes. And then get the reverse. If there's something that you've got on your list that's led one of these reversible causes, we'll talk about on the next slide, like I said, get that treated. But otherwise, you know, if somebody's flatlined or PEA, all you can do is epinephrine and continue your chest compressions, get your advanced airway in. It's a lot more simple path, I guess, than if you've got a shockable rhythm, but you just don't have as many tools in your toolbox and you have a much lower rate of success. So asystole or PEA, epinephrine ASAP, CPR, every 2 minutes reassess. Treat the reversible causes, get your advanced airway in. So let's look real quick. When we're talking about advanced airway, let's pop over here to this part over here. If you've got an advanced airway in, up here, we've got a 30 to 2 rate. When you're using a ambu bag, you're doing 30 chest compressions to 2 breaths. After you get an advanced airway in, you do not pause compressions. you go ahead and give those breaths while you're doing compressions. So you just give one breath every 6 seconds. You need to count that in your head if you're the one doing that, because what happens is you're like, and that's one breath every 2 seconds, but that's what you like, that's what your instinct is. So you need to count. That is a time where you need to 1, 2, 3, 4, 5, 6 breath. Like even in my head just then, I felt like I wanted to breathe before I finished that. So that is the gig there. You yourself are in a code. Your adrenaline's going, you're worked up, you're breathing faster than normal. So you want them to breathe as fast as you're breathing. But that's not what we're going to do. That's not best practice. That's not what is going to help your patient. That's going to over-oxygenate them and hyperventilate them and can cause harm. So we're going to do one breath. We're going to calmly count to 6 and deliver another breath for a rate of 10 breaths per minute with continuous chest compressions. So if you've got an advanced airway in, you do not pause chest compressions. You just keep on going. Okay, so we will talk about ROSC in just a little bit. So I'm not going to discuss that right now. We're going to discuss reversible causes coming up. So real quick, one more time, I'm just going to go back over the algorithm with not a pulse, neither of them have pulses. That is shockable. Start the CPR. If it's shockable, the priority is going to be to shock them. Prioritize the shock. After you've shocked, immediately back on the chest, CPR for 2 minutes. While you're doing those 2 minutes, you're getting IV access. Still shockable in 2 minutes, you shock them. Remember also with every 2 minutes, you're switching roles. All these 2-minute breaks, you're switching roles. Your compressors come in. Whoever's doing chest compressions coming out, somebody else is going in. Every 2 minutes. Your time, I will talk about roles in a code in just a little bit ago, and that timekeeper is crucial because there is a lot going on. You got to switch every 2 minutes, assess the rhythm every 2 minutes, epinephrine every 3 to 5, keeping up with when you started the advanced airway, keeping up with if you have already done a antiarrhythmic. So that timekeeper and recorder is, I mean, they are the hero of the code. I'm not even gonna lie. So, shocking every 2 minutes. First 2-minute break, IO access, IV access. We'll talk about IO in a minute too, if you don't know what that is. So we'll get back to that. Next one, epinephrine, and consider an advanced airway. Next one, look at antiarrhythmics. So we've got some other drug therapy up here. We've got amiodarone and lidocaine as our antiarrhythmics that are up here. And we've got our dosage listed. So amiodarone, first dose 300, second dose 150. Lidocaine, first dose is weight-based. These are weight-based. So what you actually see in a code most of the time is amiodarone because it's not weight-based. And usually thinking about drug calculations in the middle of a code is not your not what you're going to go to. But what you may do is amiodarone during the code, and then you may be starting some lidocaine further along if you're in a continued long code. So that is how to go through this algorithm. All right. Next up, let's look at those reversible causes. All right, so like I said, let's look at these H's and T's. So that's what we call them, is the H's and T's. These are our underlying causes for, for lethal rhythms. So these are differential diagnosis is another term you'll hear. Underlying cause, things like that. So why does it matter what is going on? If we don't know what is going on and what caused the rhythm, we can't fix it. We can't, it's not gonna fix the problem. We're gonna continue to have these abnormal rhythms till we fix the underlying cause. So let's look at some of these. And then we're gonna go through some examples and talk about what it could be. So we've got, I'm going to change back away from blue because it's not going to show up very good on this blue, hypovolemia. So loss of fluid in the vascular system. So this could be from severe dehydration or blood loss, if fluid loss. So if somebody has had some sort of a trauma or a GI bleed, anything like that, severe hypovolemia, so fluid loss. Hypoxia, not enough oxygen. This hydrogen ion is acidosis. So this is going to be if you've got a patient that's in a severe respiratory or metabolic acidosis. So if you've got that severe acidosis, remember the carbon dioxide, if you remember back to Miss Curley's, I believe it's Miss Curley that teaches it in 112 or 114, your ABGs, and looking at those, carbon dioxide is super acidic. So if you've got high carbon dioxide levels, then you're going to have a respiratory acidosis. So we want to get that CO2 out of the system and get them adequate ventilations. If you've got a metabolic acidosis, you can't fix it quite as quickly, but what you can do is add a buffer. Because a lot of times with a metabolic acidosis, you'll see that in like kidney disease, the kidneys aren't working to buffer out those acids, so we can add a buffer here we can give some sodium bicarbonate to level it out. Hypo or hyperkalemia. So if we've got a potassium imbalance, we're going to want to treat that. Hypothermia, your patient's been exposed to the cold. Somebody that's homeless comes in after drug abuse and has been out in the cold. Hypothermia, we want to warm them up as soon as possible, but not as quickly as possible, if you remember. We want to do that controlled and slowly. Toxins. So when we look at toxins, this is typically medication or drug related. So it could be an accidental overdose. So if a patient takes digoxin or beta blockers, calcium channel blockers, that can lead to a lower heart rate. Cocaine or other illicit drugs can also lead to, and then poison as well could be a cause. Tamponade, so cardiac tamponade, which you will learn more about when we talk about trauma. I think it comes along before that also. I think that it might be some of it in your Unit 2 content. So, but basically what we've got is a fluid buildup in the pericardium. So you've got the pericardial sac around your heart. You've got your heart in there just pumping away, right? Fluid starts to build up in that pericardium and it starts to crush your heart, basically. It can't pump because it's got pressure from the fluid buildup in that pericardium. So you do get some of that in Unit 2. So you'll learn more about that. So, but if that is suspected, it could be from trauma, it could be from other things. But if you suspect cardiac tamponade, then that needs to be treated, or you're not going to get it doesn't matter how many times you shock somebody or give them epi. If their heart can't pump, it can't pump, right? Tension pneumothorax. So also, you'll see, we'll talk about this in trauma, you'll also get some of this in Unit 3. And when we talk about respiratory stuff in Unit 3. So basically you've got one of your lungs, air's building up in it, shifting everything over and crushing everything. So you're not able to breathe, your heart's not able to pump. And so if you suspect that is usually seen with trauma, then we will also need to treat it. Thrombosis, a clot, right, somewhere. Heart or lungs, we got it twice here. Massive PE or massive MI. So a blood clot somewhere is not supposed to be, you're not getting oxygen where you need to. So treating those things will also, if you suspect that, then that's what you need to treat to move forward. So let's talk about some examples. So if your patient just had a heart catheterization and it was normal, or they had an intervention, or no, let's go with normal. They had a normal heart catheterization, and they went in through the artery in their leg, and your patient starts complaining of severe back pain, and their blood pressure is dropping, and they start going into a lethal rhythm. What are you going to suspect is going on? I'm going to give you guys a second to think. I'm going to suspect hypovolemia. I'm going to think that they're bleeding out because we stuck their artery and it's bleeding somewhere. They had a blood pressure drop. That is what I'm going to suspect. Next up, we've got a pediatric patient who was found in, whose grandmother has a heart condition, and the child was found unconscious. What do we think is the cause now? Toxins. I'm going to think that they had that they got in their grandma's pills, and that could be the cause. An elderly client found unconscious at home after 5 days of severe nausea and vomiting. Hypovolemia. Also, what else could it be? Hypokalemia. Somebody's been nausea and vomiting for 5 days. They're going to be hypovolemic, but they also have maybe been getting rid of all their potassium along with it. So think about that. Don't get pigeonholed into one way of thinking. Homeless client found unconscious in the winter. Hypothermia. Pause me if you want to think on these on your own. A diabetic client with bedside glucose level that is critical high. What do you think? What do you think? An acidosis, probably a DKA, is acidotic, leading to those arrhythmias. Teenager, unconscious at an unchaperoned party. Teenagers. Toxins. Okay. A client that was in a motor vehicle accident. Now this one's tricky. What do you think? Just think about that. What could it be? Could be hypovolemia. They could have bled out, right? Could be tamponade or tension pneumothorax. Could be any of those three things. It could be hypoxia if they had lung involvement. Which, you know, you can't get hypoxic with tension pneumothorax. So, but what you've got is it could be any of these things. So then you're going to look more specifically. If you had that client come in, then now you're going to look more specifically at what else happened. A client who had a total knee replacement 3 days ago. What do you think? Possibly a PE after a DVT. I have had a patient one time that I was taking care of in ICU. I don't remember why he was there, but he was doing better. And I was moving him out of ICU that day. And he was able to walk and talk. He was in his early 50s. He was a walkie-talkie about to move out of ICU. He probably had, I don't know what he had. But anyway, he got up to go to the bathroom. He was getting his stuff together to move out onto the telemetry floor. And he was walking to the bathroom and he dropped to the floor. He died. We couldn't get him back. And that's what it was. It was a massive PE. It was scary. It was one of the scarier codes I've seen. Like, he was fine. He was young. He was pretty healthy. And just like that PE, he dropped to the floor and never came back from it. Scary stuff. End stage renal patient who missed his last dialysis visit. What could that be? I know we talked about that could lead to acidosis. Kidney disease leads to acidosis. What else? If he didn't get dialyzed, he might have hyperkalemia. He may have built and not cleared out his potassium well. Let's see, COPD and had recent flu. My guess is hypoxia. They are hypoxic. Oh, sorry. Okay. And then lastly, a patient that was brought in unconscious after complaining of tightness in his shoulder and complaints of indigestion. Massive MI is my guess here. So these H's and T's are important because if you don't treat the underlying cause, you are not going to fix the problem. All right. Next up, capnography. I know I said we were going to come back to that. I've got a little video here we will watch. All right, so in the video, she's going to say that it is a new tool, and it is not a new tool. It's been used for a while, but I will say you're going to see it more and more at bedside practice. It is being utilized more and more often because it is such a wonderful tool, and it has shown through evidence-based research how utilizing capnography can improve patient outcomes.
Waveform capnography is an important new tool in the treatment of both cardiac arrest and the perfusing patient. To put it simply, capnography measures the byproduct of metabolism, CO2. If you compare it to a fireplace, it's the smoke that's measured by waveform capnography. Where there's fire, there's smoke. Where there's no smoke, there's no fire. In the cardiac arrest patient, we use capnography to measure whether we're doing compressions adequately, in which case we should have expired CO2 of at least 10. We also use it to measure whether or not the patient has a perfusing rhythm or has the return of a pulse, despite the fact that we can't feel it. Once you have a return of spontaneous circulation, you'll have a spike in capnography to at least 40, at which time you can stop compressions. Capnography sensors can be placed both on endotracheal tubes, oxygen masks, or nasal cannulas. Obviously, in the case of cardiac arrest, we prefer to measure CO2 off an endotracheal tube. In addition, waveform capnography is required to validate placement of the endotracheal tube at intubation or any time when the patient is moved. It's our only tool that tells us definitively that the endotracheal tube is where it belongs and has stayed there. In the case of the perfusing patient, capnography becomes important to tell whether the patient is underventilated or overventilated. In conjunction with the SpO2 or pulse oximetry, it can be a very valuable tool. Pulse oximetry will tell you what has happened over the past 2 or 3 minutes. Using waveform capnography, you can actually predict whether the patient is going to be in trouble or not. You do that by measuring the amount of CO2 that's being exhaled with each breath. A normal patient will exhale between 35 and 45 per minute. However, if they're not breathing adequately, their CO2 levels will quickly begin to rise. That will show up much faster on waveform capnography than it will on pulse oximetry. On the other side of the spectrum, someone who's breathing very fast or hyperventilating will blow off their CO2 much quicker, and therefore the numbers will fall dramatically, both of which will happen pretty quickly.
All right, so as we saw, capnography is a great tool that we can use. And, you know, we like to quantify things. We like to have specific things and not say, go off of a feeling, say. So this gives us some tools that we can use. So first of all, let me go ahead and talk about ROSC and what ROSC means. So you'll hear the term ROSC, and that is return of spontaneous circulation during CPR. So a few things that we can use during this for during CPR. So for one thing, it will indicate to us that we may need CPR. If we've got a very low CO2 rate, then that's going to indicate to us that there's not a that they're become a pulseless. So that capnography waveform is going to disappear before the pulse ox does. So because you may still have some oxygen perfusing that, so it may take a few minutes, but if you're monitoring somebody's CO2, it's going to stop. It's going to drop immediately when somebody stops breathing. So you get a little bit faster. If you're expecting a respiratory, remember hypoxia was one of our causes for cardiac arrest. So if you're expecting or you're watching somebody's breathing, you think that there may be a reason for cause for concern there, that capnography waveform will disappear before you see the pulse oximetry drop. If hypoxia is the reason for cardiac arrest, that would be your order where you would see the drop. Capnography stopped, pulse oximetry dropped, and then you would see the cardiac be affected by that lack of oxygen. So it can help indicate when CPR is needed. And then also remember PEA. We talked about PEA. We would be able to see that drop there too. Another thing that we'll use it for is for compression feedback. So if you should have an end-tidal CO2 reading of 15 or more. And that would indicate that you are generating perfusion with your compressions. If your compressions are generating small waveforms or it's below, showing below 10, then you could have poor compression technique, and it's a sign that there's decreased perfusion going on. If you see, you know that good compressions are happening, and you are slowly seeing that decline, like for a while it was 15 to 20 and now it's slowly dropping down and good compressions have continued, then we might have a sign that that the alteration in perfusion is evidence that we may need to stop CPR. So we'll talk about that in just a minute. It is also, like she said in the video, capnography is at the bedside the best confirmation of tube placement. Chest x-ray is your gold standard there, but if you're in the middle of a code, you're not going to be like, okay, everybody stop chest compressions and let's stop trying to save this patient's life for a minute so we can get a chest x-ray. Bedside capnography is your best confirmation of tube placement. So if you're placing an advanced airway at the bedside during a code, this is going to be your best way to check for placement, is that CO2 is measuring the capnography. Also, it can let us know that we are that we're overventilating. Hyperventilation can actually lead to vasoconstriction and decrease perfusion to the brain. So we don't want to increase that, put too much pressure in that thoracic cavity. We don't want to have an elevated intrathoracic pressure because that can impact compressions. Remember, we're trying to squeeze the heart, so too much pressure in that thoracic cavity or hyperventilation. So it can help us with that. And then lastly, this termination of CPR. Stopping CPR is one of the most difficult things that whoever's leading that code will have to do, to say, we've done this, long enough. Like, what's long enough? Like, what's the end of trying to save somebody's life, So capnography can give us quantifiable data that can help us to make that decision. So if patients have been receiving high quality chest compressions, have an advanced airway in place, and have a consistent CO2 reading or capnography reading that's less than 10, after 20 minutes of resuscitation, that can indicate that it may be time to stop CPR. That it's not being effective anymore. It's a sign that that perfusion is not present. At the same time, even if you've been going with CPR for a very long time, but what you're seeing is still an adequate capnography reading, it's 15 or above, and is continuing to climb up or stay, elevated, then that's a sign that they are perfusing and that neurologically they may be still intact, that they've had some evidence shows that that is a sign that they're going to have their neurologic functions intact following this. So that is going to be a sign that maybe we need to keep going. Additionally, it is going to be our first sign of return of spontaneous circulation, or pulse came back. So it's going to be our first sign of ROSC. So a sudden increase in that end-tidal CO2 or on that capnography reading is going to be that first sign that we'll see, even before you can feel the pulse. That'll be the first thing you see. So if you've got that going up, that is what we're going to be looking for. So we'll be looking for a capnography reading of 35 or higher is going to be a sign that circulation has returned. So, and that we can stop compressions. So it may be higher. When circulation returns, you may have some CO2 built up in the bloodstream. So then you may see an elevated capnography reading before it gets exhaled back out. So remember, if there is a waveform, a capnography waveform with ventilations, and there are no compressions taking place, that circulation is still taking place. So if you see that spike, typically between it'll need to be over 35, that's going to tell you that circulation is happening. All right, the last thing I'm going to go over right now in this video is I said I was going to go back to what IO was. So if you do not have a IV in place and your patient is pulseless and you need to be able to give some epinephrine or other life-saving medications or IV fluids, the next thing that we're going to do is we're going to start an IO, which it stands for intraosseous, so inside the bone. Intraosseous. Yes. I think I spelled that right. I may not have to. It might be an O right here. I think there's an O right there. Okay. So intraosseous, I'm going to go ahead and erase that because my bad spelling, I don't want to look at it anymore. So an IO site, there are specific places that it can go. A lot of times, if you see it, it'll be this knee, this proximal tibial. It can go sternal, but if you're doing CPR, that might be not the place you want to go. Proximal humerus, so it's going into the bone in these spots. Nurses can do these. They are specially trained to. Typically, the nurses that put these in are ICU nurses or ER nurses. Will be trained, and it's kind of like, this says driver, but it's like a gun, and drills that needle in, and then you can run fluids and administer those life-saving medications we talked about on the rubric, or not rubric, on the algorithm. You can administer through those just like you would a IV. See, just run it right through there just like you would an IV. So those are your other options if you cannot get an IV placed on your patient. All right, so that is going to wrap it up for this first part of this PowerPoint. The rest of it, we're going to talk about team dynamics. What are we going to do after we've got ROSC, and also about pediatric advanced life support. And we'll do that on the next video. Please let me know if you have any questions, comments, concerns. You are not alone. I want to help you through this. If you have questions, let me know.